Our talk today will be about orbital cellulitis and orbital inflammation, starting with orbital cellulitis. A little bit about related anatomy. You know that the bony orbit is a pyramidal cavity formed by 7 separate bones. The entrance of the orbital cavity averages about 35 millimeter in height, 40 to 45 millimeter in width and depth. The superior wall is related to the frontal sinus and is formed by the frontal bone and the sphenoid bone. The inferior wall or the floor is formed by the maxillary bone, palatine bone, zygomatic bone, and is related to the maxillary sinus. The lateral wall is formed by the zygomatic bone and the sphenoid bone or the greater wing sphenoid bone, and it's not related to any sinus. And the medial wall is formed by the, as you can see, by the lacrimal bone, maxillary bone, lacrimal bone, ethmoidal bone, and sphenoid bone, and they are related to the ethmoid sinus. The venous outflow is important in orbital infection, as the ophthalmic venous system is completely devoid of valves, and this results in extensive communication between the face, nasal cavity, and pterygoid region, and sinuses. Lcb orbital pain is formed by the confluence of the angular vein, nasofrontal vein, and the supraorbital vein. Then when they form the supraorbital vein, they pass through the supraorbital fissure into the cavernous sinus, while the inferior ophthalmic vein is formed by a network of venous plexus from the medial venous plexus and the lateral venous plexus in the inferior wall or around near the floor, and receives tributaries from the several orbital tissues. Then it courses backward in the orbit and divides into 2 branches. The first branch goes through the inferior orbital fissure and joins the pterygoid venous plexus, and the other branch goes through the superior orbital fissure and ends up in the cavernous sinus. As you can see here, these are the venous plexuses, and it passes back in the inferior part of the orbit and divides into 2 parts, passing to the pterygoid plexus and to the cavernous sinus through the superior and inferior orbital fissures. You know that the periorbita is the only soft tissue barrier between the sinuses and the orbital content, and you know that the septum originates from the arcus marginalis and passes inferior and superiorly to the and fuses with the levator muscle in the upper eyelid and the retractor or the lower lid retractor in the lower eyelid, a few millimeters above and below the tarsus. The septum is also a tough tissue that resists spread of infection from the preseptal tissue to the orbit. Sinus, about the sinuses, in newborns, they have a fully developed maxillary and ethmoid sinuses. The sphenoid sinus, it's present at birth, but not of clinical significance until 4 or 5 years of age, and rarely diseased as a separate entity. The frontal sinus usually becomes clinically significant at the age of 6 years. Sometimes they never develop. And so any patient below the 5 years of age, usually sinusitis is confined to the maxillary and ethmoid sinuses. What is the definition of orbital cellulitis? When I say orbital cellulitis, it means it's an infection of the soft tissue behind the orbital septum. It's considered one of the most important ophthalmic emergencies, as delay in diagnosis can lead to a serious complication, ocular complication like vision loss, or systemic complication like frontal abscess, meningitis, cavernous sinus thrombosis, osteomyelitis, brain abscess, and even death. It was classically classified by Chandler into 5 classes: Group 1, preseptal cellulitis; Group 2, orbital cellulitis; and Group 3, subperiosteal abscess; Group 4, when they have orbital abscess or discrete collection of pus within the orbital tissue; and Group 5, when they have cavernous sinus thrombosis. How do they present? They usually present with variable signs and symptoms, including periorbital tissue edema, warmth and pain. Orbital involvement becomes more obvious when there is a restriction of ocular motility, and exophthalmos or proptosis, and diplopia or loss of vision. So watch out for these signs. Systemic findings like high fever, fatigue, or loss of appetite might also be present. Involvement of the optic nerve may produce disc swelling or optic neuritis and can rapidly progress to atrophy, resulting in blindness. Why this happens? Due to mechanical pressure, due to compression of the central retinal artery or other feeding arteries, and also due to direct inflammation, spread of inflammation into the nerve. Differential diagnosis that you have to keep in mind includes inflammatory conditions like orbital inflammatory, idiopathic orbital inflammation, or other specific inflammation like sarcoidosis or Wagner granulomatosis, or what's called granulomatosis with polyangiitis. Neoplasm is also an important differential. This includes leukemia, lymphoma, rhabdomyosarcoma, retinoblastoma, and also ruptured dermoid cyst. Other differentials that you have to keep in mind, like thyroid eye disease, traumatic hematoma, and sickle cell-related bone infarction. How does it happen? Usually it's an extension of sinus disease into the orbit. This is the most common etiology, and this is especially common even in younger age group. And how this infection spreads into the orbit, either through the venous system, which we spoke about earlier, or through direct spread, through the thin lamina papricia of the ethmoid. Other etiological factors that you have to keep in mind include preceptor cellulitis with extension into the orbit, hematogenous dissemination, endophthalmitis, photontogenic infections, and traumatic inoculation and return foreign bodies. Which imaging modality is the first choice? Usually it's contrast enhanced CT scan. Why? It allows it to, it's readily available, fast, and allow differentiation of preceptor from orbital cellulitis, and it can also demonstrate clearly the sinus involvement, like in here, and also supraocular abscess. It will appear as a convex appearing elongated shape, either usually in the medial orbit, but can be superior or inferior even. Intracranial involvements such as epidural or cerebral abscess can also be seen. What about MRI? Usually it has been used for diagnosing intracranial complication. It's also excellent for demonstrating localized fluid collection such as abscess. Diffusion-weighted image MRI was investigated and found to be useful tool in detecting abscess as a complication of orbital cellulitis without contrast administration. And usually MRI, we use it to follow up the patient if he's not improving, to detect if he already formed an abscess, instead of repeating the CT scan and exposing the patient to a significant amount of radiation, especially children. However, it has some disadvantages, especially in children. They need sedation and the poor bony resolution. How do you manage orbital cellulitis? Once you suspect the diagnosis, complete blood count is ordered. Blood cultures, nasopharyngeal swab, and conjunctival swab are usually obtained. Blood cultures are more specific than nasopharyngeal and conjunctival swab, but it's usually negative. ENT and infectious disease consultation, if possible, in your institute. You start empiric intravenous broad-spectrum antibiotics to cover gram-positive, gram-negative, and anaerobes, depending on the age of the patient. And they found that age of the patient is a factor in the bacteriology and response to treatment of orbital cellulitis. Harris found that children less than 9 years of age, or found that children less than 9 years of age have a simpler, more responsive infection caused usually by a single aerobic infection, while older children and adults may have more complex infection caused by multiple organisms, can be aerobic and anaerobic, and usually it's more refractory to treatment, both medical and surgical. and those group usually have more complication than the children. When do you intervene or drain an abscess by surgery? So it's divided into 3 groups: emergent drainage, urgent drainage within 24 hours, or watchful observation. For the emergent drainage, it's for any orbital or supraorbital abscess in patients with compromised vision, regardless of the age. Urgent drainage is usually restricted to anybody over the 9 years of age, any age with large superior or inferior supraorbital abscess, any orbital abscess or supraorbital abscess from a dental source, because they usually have nasty infection, any evidence of intracranial extension, and if you find gas within the abscess, which might indicate an anaerobic infection. Watchful monitoring has been found to be an option in patients younger than 9 years of age, where you predict a simple infection. And I urge you or advise you to read this paper. It was published in 1994 by Harris, which he will be mentioned several times during this presentation. Okay, so we finished orbital cellulitis. We'll go to orbital inflammatory disease, particularly idiopathic orbital inflammation. Well, it's a poorly understood orbital-specific disorder, not associated with systemic disease. It was nebulously defined as a constellation of clinical and radiological findings without a clear etiology, and the immunopathogenesis is...
Pero parang mas maganda pag nalagyan, no? Parang mas maganda pag nalagyan. Oh.
Just give me a second. Okay, so there is a classical presentation for abrupt onset, typically over hours of pain and periocular edema, sometimes associated with chemosis and diplopia, and this is not difficult to diagnose. And you keep in mind that any tissue of the orbit can be involved, but there are a particular propensity for the lacrimal glands and the extraocular muscles. Study done by Gan and Robin. They found over 69 eyes. They found that dacryoadenitis, or 69 orbits, they found that dacryoadenitis is most commonly involved part of the orbit, followed by myositis, followed by dacryoadenitis and myositis, followed by orbital apex inflammation, and followed by other tissues like the perineuritis, preseptal tissue, tenon, sclera, orbital fat. And also they found that the majority of patients with IOI, diagnosed with IOI, had either pain or periocular edema on presentation. So having said that, it's important to recognize that IOI, or idiopathic orbital inflammation, can present as a constellation, or typically present as a constellation of symptoms and sign, but no specific sign or symptom is pathognomonic. Yan reviewed 319 patients with IOI or lymphoid tumor. IOI means idiopathic orbital inflammation, and found only that the only statistically significant difference with, which was rare in lymphoid lesions, and palpable mass was more common in lymphoid lesions. He did not report on the significance of symptom clusters. Another study on the ocular external lymphoma, on the other hand, showed that 20 to 30% of lymphoproliferative disorder presented with pain and inflammatory signs. Another study by Goldman and Rootman, they reviewed orbital metastatic disease and found that inflammatory presentation to be very uncommon. However, it is certainly possible. So again, it can be masqueraded by other diseases. So what should I do when I see a patient? All patients with suspected IOI should undergo complete workup before empiric treatment started. This will include detailed medical history. So keep this in mind when you see a patient. Ask him about the presence of constitutional symptoms, history of malignancy, smoking, respiratory symptoms. So you're trying to find a reason why this is happening other than idiopathic orbital inflammation. So these symptoms represent either malignancy or autoimmune diseases. If the patient is immunosuppressed, you have to know about that. And women ask about the last recent or the most recent mammography. And in men, the last prostate exam and prostate specific antigen results. So if they didn't do it recently, you might order these too. If they have any patient with suspected IUI should undergo orbital imaging, and usually CT is enough. If you find a bone erosion or bone involvement, this is atypical IUI and do a biopsy. If orbital or cavernous sinus involvement is suspected, do an MRI to assess the extent. Baseline serologic workup, usually we order these, includes CBC with differential, AS on lysozyme, C ANCA and P ANCA for vasculitis, ANA, SSA and SSB, rheumatoid factor or anti-CCP, HLA-B27 can be ordered too, and thyroid function and thyroid stimulating immunoglobulin or thyroid stimulating hormone receptor antibodies. So if the patient have unexplained respiratory symptoms or history of significant history of smoking, do a chest imaging. I spoke about the mammography and the prostate workup. And don't start the steroid until you review the image. So you make sure that you're in the right track. But you can start this empiric treatment with steroid before the results of the serology. So you don't delay the treatment of a painful condition. And management usually is divided into 4 options. 1, observation. 2, medication, which is corticosteroid and or other immunomodulators, plus minus non-steroidals, radiation, and surgery in the form of biopsy and surgical debulking. So few, if any, orbital specialists would recommend empiric treatment with radiation without tissue biopsy. However, empiric corticosteroid, on the other hand, remain the cornerstone of idiopathic orbital inflammation treatment in most centers. There are some people who criticized this approach based on several grounds, including the argument that empiric treatment for such a condition is cavalier. So they are asking that you do biopsy before you start empiric treatment, and we'll discuss both parties here, and we'll try to reach a conclusion. Although it's no certain group is 100% correct. So whenever you see a patient with orbital inflammation or idiopathic orbital inflammation, tell him that you cannot make a definitive diagnosis without a tissue biopsy, even if you're going to start empiric corticosteroid treatment. The patient, he has to know that he will need close follow-ups over time, and to make sure that you're ruling out other possibilities. So why should I start steroid immediately without taking biopsy? So this is another argument that we have to discuss. Well, typical or classic IOI is usually diagnosed by clinical exam and imaging. And usually they respond quickly, and it's very sensitive to corticosteroid at the appropriate dose. Even in atypical cases that usually you do biopsy for them, it's uncommon to find a diagnosis other than orbital inflammation. I spoke about some anecdotal cases of malignancy and lymphoproliferative disorders, but these cases probably represents numerator without a known, but a likelihood, in all likelihood, a very large denominator. how do you give the dose? One possible thing that usually happens with corticosteroid treatment is the inappropriate dosing, or you're not giving enough treatment, which might be interpreted as a treatment failure. So once you see the patient, it's important that you pulse the patient with a very high dose initially, followed by a tapering dose over several weeks to months, usually between 6 to 12 weeks. In our institute, we do it between 2 to 3 months. We start with 1 milligram per kg per day, and then we taper it. And again, it's important to monitor compliance. So patients with on steroids, they might not be compliant because of the complication, and you have to recognize it. And you need to follow these patients and ask them to see their family physician to monitor their diabetes, hypertension, and so on. Some patients will fail to respond or even recur with attempted steroid taper. And these patients might need or require steroid-sparing anti-metabolite treatment or biologics, which has been recently used in these cases. So the question is, why not biopsy everyone? It will make you more comfortable in your diagnosis. Well, from an epidemiologic and public health perspective, some might say that you're performing a significant number of unnecessary surgeries. And this is meaning of unnecessary depends on one's opinion about the controversy at hand. You remember the study we spoke about at the beginning, or this one. Who localize the inflammation to these organs, and the ones that they said that pain and periocular edema is a common presenting symptom. They also mentioned that 29% of patients were biopsied for a variety of reasons. So in another way, 71% of patients responded rapidly to empiric treatment, and they did well without surgery. And as you all know, orbital surgery carries significant risk, and the rule is morbidity increase with the depth of dissection. For example, lacrimal gland biopsy is a more simple surgery, and it is several order of magnitude safer than a biopsy of an orbital apex lesion. Also, depends the morbidity increase with the type of tissue being sampled. For example, if you take a biopsy from the extraocular muscle or the optic nerve sheath, the risk of complication is more. Even those who argue against empiric corticosteroid treatment, they have exception to the rule, and usually they will be extra careful regarding the biopsy, the option of biopsy when there is an inflammation in the orbital apex or the extraocular muscles. One issue with the biopsy that it might be inadequate, meaning you get a biopsy, not enough. It was interpreted as a normal or non-specific inflammation. And keep in mind that it's not uncommon to have a peripheral inflammatory response in cases of malignancy and lymphoproliferative disease. And when you do that, you don't just miss the diagnosis, but you have a false sense of security that now your idiopathic combat inflammation is a biopsy proven. So another thing that you have to keep in mind if you're going to biopsy, the corticosteroid therapy should be withheld if possible for at least 2 weeks. Why? Because it might change the histopathology. So now I said don't biopsy and biopsy at the same time. How do I approach these cases? This is an algorithm adapted from a paper by Harris that was published in 2006. You might keep it in mind when you face a case like this. When you have a typical idiopathic orbital inflammation, you might start systemic corticosteroid. If they have a sustained and rapid response, you taper the dose. If you have poorly tolerated side effects, consider intraorbital steroid or non-steroidal radiation, and consider also biopsy before you start these or before you do that. Radiation, rheumatology consultation for immunosuppression if needed, and if they have poor response or recurrent despite adequate biopsy, consider adequate dose, consider biopsy. If it shows non-specific inflammation, consider immunosuppression. If it shows a specific inflammation, do your tailored systemic workup, and again, coordinate with your rheumatologist for appropriate treatment depending on the type of disease. If it's neoplasia, treat accordingly. For atypical cases, usually we go for biopsy if it's that is a tissue with low morbidity, like the lacrimal gland or orbital fat. If it shows non-specific inflammation, you start steroid. If it shows neoplasia, treat accordingly. And if you have a specific inflammation, so we'll repeat the lecture now. Okay. If you have specific inflammation, again, discuss it with your rheumatologist to give the appropriate treatment for that disease. And by that, we conclude the presentation. Thank you for your attention. Any question? So no questions. So if there are no questions, thank you for attending. And that's it. Thank you.
Dr. Hamad?
Yes.
There is a question from Dr. Malik.
Oh, wait, let me see. It's in the chat. Okay, chat here, yeah. And what's the first choice of IV antibiotic? So this depends on the institution. In our institution, we start with 2 antibiotics because we face a lot of cases of MRSA. We start with vancomycin and ceftazidime or ceftriaxone, depending on the age of the patient. And in adults or patients above 9 years of age, we add to them a coverage of anaerobes like metronidazole. I know some institutes that start only single broad spectrum antibiotic for patients under 9 years of age with simple orbital cellulitis. But again, this depends on the protocol of the institute. You're welcome. So I missed the chat. Any other questions? Okay, thank you.